Hello, everyone, and welcome to today's office hours on COVID-19 planning and response. My name is Natalie Matthews, and I'm going to give a very brief welcome and overview of logistics, and then we'll turn things right over to our experts today. Next slide, please. So, brief overview of logistics for today. As all of you have hopefully already discovered, all participants are muted and will remain muted for the duration of our time together today. You do still have two ways that you can connect with us throughout the office hours today, and that is through either the chat function or the Q&A. So if you look on your screen right now, you should see what looks kind of like a chat bubble. If you click on that, again, it will allow you to connect to the chat functionality, which we're encouraging you to use to more informally connect and communicate with one another and the experts throughout our time together. If you look to the right of that chat bubble, you'll see three ellipses, and if you click on that, it will let you open the Q&A functionality, which is what we will all be looking at throughout our time together today to answer any questions that you all submit. If we are unable to answer your question today, we ask you to please follow up by asking questions through HUD's Ask a Question desk, and we'll respond to you that way. And just as a quick reminder, this event is being recorded, and both the recording as well as slides and the transcription of today will be shared on the HUD Exchange after our meeting today. With that, I'm going to turn things over to Norm Sutar, who's the Director of HUD's Office of Special Needs Assistance Programs. Norm?
Thank you very much, Natalie, and welcome everybody to this office hours call. I know many of you were tried to get on a webinar we tried to hold a few days ago. Unfortunately, we overwhelmed the software and it just couldn't keep up with the interest, so there's clearly a lot of interest in this topic. We recorded a webinar. Hopefully you've had a chance to view that or at least view the slides. For the purposes of this chat, we sort of are assuming that you've had a chance to review that webinar and those slides and maybe some of the other materials. We have some brief updates we would like to provide for you today. Obviously, things are moving very quickly. And then, so after the quick updates, then we will just go into question and answer time. Again, you can ask questions a couple different ways. You can do that through the chat box or through the Q&A box. If you have a specific person that you would like to hear from in response to your question, please note that, or at least their agency when you ask a question. We also strongly encourage you to, if you want to have a discussion with other communities or want to throw a question open to the audience, you can definitely do that in the chat box. So if, for example, you want to know what other people are doing in this scenario, please feel free to put that in the chat box. And if you happen to know the answer to that or have an example you'd like to share, please go ahead and type those into the chat box. And we will certainly try to get to those as much as possible. If you want to say something to the entire audience, just make sure that you click the All Attendees button when you put in your chat message. If you just want to send a message to a panelist or to all panelists, then go ahead and hit the All Panelists button. But feel free to send out questions to your peers who are struggling probably with many of the same things you're struggling with. We will have two quick updates. We will have Jay Butler from the CDC will give a quick update, and Marlisa Grogan from the Department of Housing and Urban Development will give a quick update. But we have several other people who are available to answer questions, including you can see from the CDC, from HUD, from the National Healthcare for the Homeless Council, from the Department of Veterans Affairs, and from the Health Resources and Services Administration. So with that, I'm going to turn it over to Jay Butler, who is going to provide a quick update from the CDC. Jay, take it away.
Great. Thank you, Norm. So just to start with a little level setting in terms of where do we stand with this pandemic. About 15 days ago, we entered a new phase of the pandemic because there were more cases beginning to be diagnosed outside of China, where the virus first emerged, than inside of China. Currently, the hotspots include the European Union, particularly Italy, with over 15,000 cases now. There's over 2,000 cases each in France, Spain, and Germany. There's also another hotspot in the Middle East, the Eastern Mediterranean region, with over 10,000 cases diagnosed in Iran. Here in the U.S., there have been over 1,600 cases reported from 47 different states and also the District of Columbia. Unfortunately, we've seen a little over 40 deaths. The vast majority have been in a long-term care facility in Washington State. I just want to end this by thanking you for your interest because I think a public health crisis like this really highlights the health disparities that exist when it's sunny and 70. And now that we're in a pandemic situation, we're all concerned that the health disparities that exist at baseline can be even further exacerbated. So thank you for your interest, and look forward to talking with you further.
Thank you very much. And now I'll turn things over to Marlisa Grogan from the SNAPS office here at HUD for a quick HUD update. Marlisa?
Hi, everyone. I wanted to first flag again our infectious disease resources page on the HUD Exchange. Additional materials have been posted recently, including guidance on how to use COC program funds for preparedness and response activities. So we're constantly updating that with HUD resources as well as the resources from our federal partners, Healthcare for the Homeless. So please make that page bookmarked and so that you can access it and keep checking back. We're looking for ways to make it easier for HUD-funded recipients to direct funding as you need it in the quickest way that you can, so please be aware of that. If you have a question, submit it to the AAQ, but we're thinking through things like waivers, how to expedite the amendment process, so we know that that's on your mind and it's on our mind too. When there are a couple of issues that seem to be bubbling up in a lot of communities, one of which is quarantine and isolation accommodations, how to do that, when to do that. The one important consideration that I want to emphasize right now is that people experiencing homelessness that's one of a number of vulnerable populations that may need to be referred to these accommodations. So we're cautioning communities against segregating people experiencing homelessness for like specific quarantine spaces. So close coordination with public health authorities, that's really essential for continuums of care. And the public health agencies in your locality, they are in many cases likely to have greater leverage in securing spaces for this purpose, especially since we're not necessarily talking about homeless-specific quarantining. And then I also wanted to raise the issue of homeless assistance providers accessing supplies. So at this point, we'd encourage continuums of care to contact their state leadership to push for increased access to supply chains. We know that homeless assistance providers aren't always the first look when it comes to making sure that supplies are stocked up. So COC leadership, it's a good idea to reach out to state leadership to push for increased access to those necessary supplies for sanitation and other preparedness activities. And I think I can turn it back to you, Norm.
Thanks, Marlisa. So we have several pages of resources. We'll be sort of scrolling through these as we go through the question and answer process. I'm going to throw out, we already have a lot of questions coming in, which is great. Please keep them coming. I'm going to throw out some general questions to get started. So Marlisa, I want to start with you. So there are a lot of concerns about keeping shelters and outreach programs open during this whole crisis. can you talk about should providers be considering canceling their street outreach or sheltering operations? How should they be thinking about that?
Well, so we strongly recommend that shelters work closely with their local public health departments before denying anyone to shelter or before terminating their street outreach programs. The way to look at it is if you're turning someone away from your shelter, where are they going to go? If they need to be tested for COVID-19, how is the follow-up going to work if they're not welcome to a centralized location like a shelter? So, in many cases, shelters are first responders, and it's so important for this vulnerable population with underlying health conditions in many cases to still have access to shelter, to street outreach workers. The job that you all are doing is just so important, so vital. It is a matter of life and death, and so that's why we would strongly encourage maintaining operations while at the same time considering, how you need to alter those to protect staff, to protect other shelter residents, to protect people who are healthy, and to connect people who are ill to health care as quickly as possible.
Great, thank you. And a couple questions for CDC. How should shelter providers be isolating shelter residents who are ill? What sort of steps should they take? How would what would you tell them to do?
Yeah, this is Jay Butler, and let me start by just acknowledging how challenging that can be because the population of people who are experiencing homelessness often have cough for a lot of other reasons. They also, it's not uncommon that people will have fever and the general respiratory symptoms that would be consistent with COVID-19. However, at this time, I think it's more important than ever that people who are coughing and obviously ill be separated from those who are not ill as much as possible. How that's done is really going to depend on the shelter layout. And yeah, a separate room is great, but I recognize that most shelters are not going to have that. So it may come down then to setting aside areas where people who are coughing would be basically placed together, recognizing that not all of them will have COVID-19. While it's not perfect, I think it's a better solution than turning people back out onto the street if they have fever or cough.
So yeah, this is something just to add that, so as Dr. Butler here is suggesting, if you can shelter in place, preferably somehow physically secluded a bit away from other folks, and particularly if you have another bathroom that can be used, that's often helpful. I do want to emphasize again that while when doing medical procedures that are in a healthcare environment, we are really pushing strong PPE that includes airborne, like N95 masks or protective equipment for healthcare workers. This is a respiratory droplet. That means that it falls down, it sits on things that are inanimate, so cleaning does help. Washing hands makes a huge difference. So that's one of the main things that we can do in our shelters is really increase our capacity to wash hands and be reminding folks to do so, not touching our faces. If we can get some surgical masks, people that are coughing should wear a surgical mask. All of those measures will go a long way from preventing transmission in that shelter setting.
And recognizing that many of the people on the line are in healthcare, just to put it into infection control language, the primary mode of transmission based on the epidemiology that we've observed to date, as well as what's known about the other coronaviruses, is primarily respiratory droplet. There is not a lot of evidence to suggest airborne transmission with the exception of possibly in healthcare settings. Fomite transmission is also possible. We know that the virus is able to survive on surfaces for a period of time, and although in laboratory conditions that period of time may actually be days, that may not exist very often in real-world settings. So I think it's more important to think of the contamination of surfaces being on the order of minutes to potentially hours. So wiping down with household disinfectants that have virologic activity is an important part of the step as well. And we do recognize that for the population of people experiencing homelessness, the whole family of wash water diseases can be a challenge. But this is going to be more important than ever for the people we take care of.
So we had a few questions, and I think you were sort of alluding to this, but for the less technical and healthcare focused of us, can you talk about, like, when you're cleaning surfaces, what exactly should you be using to clean surfaces, and how, like, what are steps that, other than sort of spraying something on and wiping it down, like how should people be thinking about cleaning surfaces?
Yeah, we clearly want to remove any visible dirt or grime, because that makes it hard then for the disinfectants to be able to get onto the surface. The type of disinfectants, there's really a wide variety of household disinfectants that may be bleach-based or maybe alcohol-based. I mean, there's actually a wide variety, and you may be surprised to look at the indications on some of the labels. They will actually discuss coronavirus, and that's based on some of the previously identified coronaviruses. The laboratory work to date suggests that the COVID-19 virus behaves very similarly to these previously recognized human coronaviruses in terms of its susceptibility to these disinfectants.
And so again, the actual process of, what's the proper verb? Actually rubbing something, using some kind of topical.
I'm picturing scrubbing
spray.
bubbles.
Yeah, right, yeah. Exactly. The actual scrubbing or wiping actually does have an impact here. So again, there are products that are just over-the-counter things you buy at any household, product store, and they will work. And the actual, process of scrubbing or wiping actually does make a big difference. So, and again, it's the same with the hand sanitizers, like soap and water and hand sanitizing both work, but it also works because you have to actually rub your hands together with the product for 20 seconds. It's not about letting the water run and maybe putting a little soap on them. There's an idea here of actually allowing the hand sanitizer to dry. Rub your hands together. Make sure you're doing it for 20 seconds. It's the same concept. When you're wiping things down, you really need to wipe them down. But it's not any more complicated than that.
Yeah, and maybe just to summarize it a bit further, it's not anything extraordinary, except it is more important now than ever, and the frequency may need to be increased. Over.
Great, thank you. So we have some questions about like shelter staff and steps they should be taking to sort of protect themselves, which obviously, like, protecting yourself is about more than just protecting yourself, but can you talk about, like, if you are interacting with a lot of shelter residents, some of whom, may exhibit some symptoms of illness, and maybe it's COVID-19, maybe it's something else, but what steps should shelter and street outreach workers be taking to protect themselves?
Yeah, the first and foremost important thing to do is hand hygiene. Being aware that hands can become contaminated and can be a vector for transmission, not only to other people, but also to self, particularly if the hands go to the face. If workers are interacting with people who are actively coughing, that's the situation where use of other types of PPE can be useful. We've recently updated.
I'm sorry to interrupt, but that acronym you use, can you spell it out for us?
I'm sorry. Personal protective equipment.
Uh-huh.
We're very prone to doing that, not only in healthcare but in government. So I've got two strikes against me right off the bat. The use of masks is a bit more controversial. If you are someone who are a healthcare provider actually collecting a specimen, for instance, that's where we would recommend use of an N95 mask. And we continue to review those guidelines to make sure that we're doing what's appropriate to protect people, but also not overdoing it, recognizing that the supplies of these equipment can become limited and are becoming limited in some parts of the country. For standard interactions just with the general public, things like masks probably aren't of any benefit. Particularly surgical masks don't actually provide any filtering capacity. And you are probably aware that the CDC does not recommend mask use in the community in general because there's really no good evidence for efficacy. Plus, just anecdotally, and this may be more my observation, wearing a mask oftentimes forces people to place their hands to their face, particularly if they're prone to frequently adjusting the mask.
Yeah, I think the other thing is if you can, so for example, I'm just picturing the shelters I've worked in before, if intake can be outside initially and that's feasible, if there can be a little bit more distance created when the worker is first talking to folks as they come in, 3 to 6 feet as opposed to people being as close as we often get to each other. So a little bit of that social distancing. Again, this is where the whole idea of droplets versus airborne comes in because you have to think about how can we minimize someone coughing on you. That's what we're really talking about when we get to the nitty-gritty of it. So if we can make a little bit more space, that is always very helpful. And then again, if someone is coughing and symptomatic, that's the one situation where if you can give them a surgical mask, that might be helpful that when they're coughing in that mask. If you can't, give them a tissue, remind them of cough etiquette, like have them use a paper towel or something that they're coughing into something, not their hand. Elbow is better than hand, but a tissue or something they can throw away is better than elbow.
Yeah, and Sapna said it perfectly in terms of the reason we would put a surgical mask on someone who is symptomatic. It's to give them something to cough into. It's not filtering the air, but it's basically creating a splatter shield for someone who may be coughing. Respiratory droplets are generated during coughing and sneezing, and it's that spray when people cough or sneeze that can spread the virus.
Got it. Incredibly helpful. Thank you. So we've had some questions about screening tools. So is there a sort of a particular screening tool that shelters or outreach workers should be using to determine like risk or, if they should elevate or when they should contact their health department or anything like that?
Norm, is that to us, or is that something, Marlisa, you want us to address first?
Let me ask Marlisa first, and then, sorry, I should have mentioned.
Perfect.
Marlisa, do you want to take a first crack at this? I think you may be on mute.
I knew I was going to do that. So, this can be logistically challenging. If you have clinic staff that are co-located in your shelter, if you're a part of a street outreach team, we have a street outreach program that also includes medical staff, that's an ideal way that you can identify clients up front who may need immediate medical care and follow-up. But if not, it's really important for continuums of care, public health, local healthcare providers to decide on the protocols that shelters and street outreach programs should follow. It's also important at this point for continuums of care to know and to set up protocols among their shelter and street outreach programs, what questions you're going to ask and then where you're going to refer folks. So that includes close coordination with local healthcare providers so that they're aware and that they can accept these referrals. I think that I'll turn it back to Sapna and Jay when it comes to questions that can be asked and the best way to approach the individual conversation.
Great, thank you. And Sapna and Jay, do you have additional thoughts about screening tools?
Yeah, so I will say, again, this is this is really where we need your all's expertise on what's feasible. But what I will tell you is that we are in the process here of potentially posting a kind of self-symptom checker. And so it would be something that can be used by anyone in the public. I think it could be very helpful, for example, a shelter director, where you basically would ask a series of questions of someone who you might notice has symptoms, or if it has a fever, and then you could go through basically, in lay terms, an algorithm where you would, be asking certain questions, filling out certain answers, and it would suggest things like this person shouldn't, maybe stay in the shelter, maybe they need to go to the hospital, or maybe they need to be isolated, or maybe, right now the way it reads is of course, for folks to maybe home quarantine. That's not going to be a solution here, but we hopefully will locally be having answers to where folks can, quote unquote, be isolated during a quarantine phase. So as that becomes more available, we'd love to push that out, and maybe we can federally here work with HUD on adapting that tool so it's something that shelters could use in places where we decide to be more active.
So I think I can speak on behalf of every shelter provider and say that would be incredibly helpful, and obviously, you have a lot of people who would be happy to work with you on that here. So yeah, I think that would be incredibly, incredibly beneficial. Barbara or Jay, did you have any other sort of additional thoughts about that, or any additional guidance for people? Okay. So we got a lot of questions, so going to keep these coming. So there's a question about performance, and maybe we can sort of direct this to VA first, and then I'm happy to answer this on behalf of HUD. But has there been any discussion about how this might affect agency performance as it relates to contracts with federal agencies? And will there be any consideration of this on contracts, payouts, future NOFAs, any sort of thing like that? So Dina or Jillian, do you want to, is this something you think you can answer on behalf of VA? And then I can take a stab from the HUD side. And you may be on mute, because I don't think we can't hear you right now. I think we may have lost
Jillian. You're off mute.
Yeah, I think we may have lost Jillian from the. Let me go ahead and answer on behalf of HUD, and then we can talk about if they can come back on. But so the short answer on from HUD's perspective is we really don't know yet. Obviously, we do sort of annual funding competitions, and we just don't know how we're going to handle this. We are obviously just very focused on trying to get through the next few weeks and months and just do as much as we can on the front end, that we really haven't sort of thought through how to think about this on the performance side. It's something that obviously is so big and important that we're going to have to do something about this. We just, I don't think we have an answer for that yet. But it's certainly something we're thinking about and something we'll be paying attention to. But it's something that, we don't have an answer to quite yet. And so, Dina, I don't know if you had some things you wanted to add there.
Hey, this is Dina Husso. Can you hear me now?
Yep.
Wonderful. So I echo what you just said, and also thank you for inviting us to this webinar. It's very educational. We are currently doing that assessment as a VA institution in general, though in terms of definite of how it'll impact contracts, that's yet to be determined. And I would think that this is also a question for the community in general in terms of how to face the situation where maybe a majority of their healthcare workers are not able to perform their functions because they are sick or taking care of people that are sick.
Great, thank you. We have a question from Allison, and I'd actually throw this out to Marlisa first, and then I don't know, others may have some answers as well. But a lot of shelters are wondering, how do you quarantine people when you have such limited space? And I think this also applies to the issue of creating social distance, right? We don't want people sleeping right next to each other. So can you talk about, like, what are some options for people that find themselves in that situation?
Well, CDC came out with some really great guidance for homeless service providers, and it goes into distancing, and then also positioning beds like head to foot, and putting up partitions. I think that, and Sapna can correct me, I think it's a distance of at least 3 feet between shelter residents. And then also just thinking about, the layout. Jay also alluded to this. A lot is going to depend on the space. I know that some communities are also thinking through, just overflow spaces. And to just make sure that, we're clear about the point I was making earlier, when it comes to overflow spaces for quarantine and isolating folks, that's where we'd caution against segregating people experiencing homelessness, since they're one of many vulnerable populations. So I know that communities are thinking through motel options, hotel options when possible, so that there is enough space within your shelter so that you can do the social distancing, positioning beds. I'd also kick it over to CDC to see if they have anything else to add.
Sapna, Jay, do you have things you think people should know?
And this is specifically about spacing or about isolating or sheltering in place, kind of?
Both, actually, and maybe some options for, like, a lot of shelters obviously have limited space. They try to serve as many people as they can. Like, how do you sort of maximize that equation there about safety and space? Yeah.
Yeah, so first of all, I want to not throw my public health department partners under the bus at all, but I do think this is where some local coordination really, really is important. And I understand that, like many of you, the health departments right now are very overwhelmed. They are dealing with a lot. And, but I think we have to make every effort we can to have our shelter providers, our HUD grantees, our HCHs, and our health department staff come together to try to come up with a plan. So first of all, that should be happening behind the scenes. And I realize, again, that that's not always easy, but we have to make our best efforts to find a way to make that conversation happen. The reason I say that is because obviously everybody brings different resources to bear, and there have been, we've heard about some of our West Coast partners coming up with solutions like, I think San Francisco has 30 trailers that they've outfitted to isolate people while they're symptomatic and we're waiting on a test result. There are other folks that have identified different buildings. Some people are opening their winterized shelters, to continue to shelter folks that might be waiting for a test or might be coughing. So there's different solutions happening out there. So that's the number one thing. In terms of sheltering in place, and I agree, 3 feet, ideally 6, but not if it's going to mean you're going to turn folks away. So if at least can be 3, that'd be, better. Head to toe or toe to toe, depending on how many rows you have. Basically to, do the best you can with, making sure that folks that are coughing are not, within that close enough space to be coughing on folks that are asymptomatic. And that's, unfortunately we have to do the best that we can do with what we have. Barbara, I think, DePietro, you might be able to add something as well. Sorry, Jay.
Yeah, and is this working with the mute?
Yep.
Okay. And I also wanted to say that the guidance that HUD has put out for COC providers is really good in having a lot of options that shelters can look at to think about what's possible for augmenting existing space. So whether that means putting up physical barriers or finding some way to be able to create quarantine space, even though it may be tight. I think a lot of this is just creativity. And I think this is a perfect opportunity to partner with your public health authority or your local HCH, that someone can come through and take a look with you to see where could you create some isolation areas that would at least be harm reduction for your general operation. So I just wanted to put that out and refer back to the guidance that had a lot of those ideas.
Great, thank you very much. We had a question from Susan about Stafford Act. And would a Stafford Act declaration have any impact on HUD funding in particular? The answer is mostly no. That it wouldn't in the case of an emergency designation under the Stafford Act. And I'm not sure if that's been activated yet or not, but wouldn't have much of an impact on, or any impact actually, on ESG or COC funds. However, there are a lot of flexibilities in ESG and COC that people have, and we have put out a couple, as Marlisa mentioned, we've put out a couple documents that sort of describe some of the eligible activities under ESG or COC that you can use, and if there's a case where you need an amendment to make it work for your grant, please reach out to us. We are working on ways to expedite that process because we know how important this is. So that's sort of the short answer, but we will obviously, as circumstances change, and I know Congress is doing stuff as well, as circumstances change, we will get information out as quickly as possible. And as these resources are flipping through, we will make these slides available as well, but as these resources are flipping through, you should be checking fairly regularly back at the HUD Exchange and USICH's website and VA's, HRSA's, and Healthcare for the Homeless. There are a lot of organizations that are putting out resources. You should check back regularly because this is something where things are going up every day, and there's always new information, and so those are the mechanisms we'll use to keep you informed. Also, if you are using HUD resources, you should definitely sign up for the HUD listservs because that is also a way we push out information. Great, thank you. And let's also just want to say we've had a lot of community-specific questions. We won't be answering a lot of those here. We want to answer more general questions. But if you have specific questions that we don't get a chance to answer, please send them to the AAQ through the HUD website, or contact one of the other agencies if you are, if you're a grantee with one of the other agencies, and we'd like to be able to answer some of those more specific questions as well. But I know we've had a lot of, one example about something I want to sort of throw out to the general audience to just post in the chat box. If you've had some experience with this, but we had a question about hand washing stations and portable sinks, and whether cities or counties or states, I'm sure, have had any luck quickly getting portable sinks or hand washing stations implemented or put up in places where there are encampments or other areas with a lot of unsheltered people. If you have examples of that, please go ahead and post that. That kind of information is really, really helpful. Thank you. Next question here. So a lot of people are having trouble accessing hand sanitizer and other cleaning supplies. I wonder, Marlisa, if you can talk about, any ideas you have for how people can access those cleaning supplies and those supplies. if they're, everyone's going to Costco and the grocery stores these days. But what other options do people have?
Right now, at this point, when it comes to continuums of care, trying to get access to those supply chains, it makes sense to contact your state government and just impress upon them how there's a need at the shelter level for those. That would be, I think, the most effective and direct way to try to get into the supply chain route. But if things change, there may be a way to, like if FEMA got involved, that's, I think, more the time when federal input and influence could assist you at the local level with access to supplies. But right now, at this point, at this stage, we would recommend that you contact your state government for that.
And Barbara, do you have some thoughts here?
Yeah, I just wanted to mention that Seattle, in its response, their local government has organized all of the supplies around a central distribution methodology. And so they're able to triage across the community by having everyone pool into one coordinated system. And so I think that's been very efficient. And if local communities can do that and include high priority populations like homeless service providers, that would be really helpful.
Great. And I think like what I've been noticing is that there are a lot of states that at the state public health level, there is, they have some control over the flow of supplies and prioritizing who gets supplies. And I think this is a comment Marlisa made earlier about the importance of coordination between either the COC or the whoever's running the shelter system and the state public health infrastructure to make sure that you're appropriately prioritized for cleaning supplies, for hand washing, for other medical supplies and other things that would normally sort of go to first responders, but in many cases it makes a ton of sense to have them go to emergency shelters. Also, if there are any state government people or state public health people on the line, strongly encourage you to reach out to your COCs and make this connection here, because again, it's incredibly important. We have a lot of very vulnerable people in emergency shelters and sleeping outside, and a lot of workers who are at very high risk and trying to do good work here, and making those connections and appropriately prioritizing that stuff is really important. And Sapna and Jay, do you have other thoughts about when people are struggling to get supplies and such, how they should proceed?
Yeah, I think the advice earlier about checking with state and local health agencies as well as response agencies are important. I don't have a lot of visibility on the strategic national stockpile and what they may have in terms of the types of materials that we're discussing, but the public health preparedness directors at the state and local level might. That's actually a federal asset that is not under CDC, but could be potentially very useful.
Great, and we have some questions about food programs as well. People just operate meal programs that are sort of independent of a shelter or maybe connected to a shelter in some way. How should people be thinking about those kinds of programs, and what steps should they be taking? Marlisa, do you want to take a first crack at this question?
Can you repeat that, Norm?
Sure. So we have questions about food programs and meal programs. So, you'll have your regular sort of breakfast program that may or may not be attached to a shelter, but it just sort of generally serves people experiencing homelessness or other low-income people. But obviously there's a high risk of transmission in those settings. So can you talk about, how should people think about that? What steps they should be taking in that context?
Right. So, I think that there is, and we are not making this up. There is guidance that's out there and posted that you can refer to after this. So, you know, you don't even have to take notes. It's there, but you need to think about, you know, all of the typical precautions: wearing gloves, ensuring that, you know, any sort of non-disposable utensils are never shared. They have to be cleaned before they're reused. Think through congregate feeding situations so that, you know, if people are clustered together and they're eating together, you know, encourage social distancing in those types of situations. Obviously, you want to encourage, you know, not sort of like family-style sharing of food or people handing out or, you know, dishing out their own food, but that it's, I think some communities have handled this in maybe packaging up, you know, like a sort of like a, you know, pre-prepared, you know, food, like distributing food that way. Having, you know, encouraging people to wash their hands prior to stepping in line to get food, having hand sanitizer handy. Those types of things can really help minimize infection spread. So yeah, but I think the point is to really think through that process and notice how you're typically doing things, and then adapting them to incorporate like those protective measures, and then enforcing it, because you know, that's sometimes the hardest thing to do, to making sure that people are washing their hands before they're eating, and using the hand sanitizer and not sharing, those types of things. Norm, I think you're muted.
Thank you. Sorry, this question is for CDC. We have a lot of projects that provide in-home services of some sort, regular sort of case management visits or other kinds of visits to people who are living in permanent supportive housing or in a rapid rehousing program or in other contexts. When we think about home visits, what kinds of protective measures should we be thinking about? Should people be thinking about moving to virtual visits, either, you know, teleconferences or just phone calls? Or like, what are steps people should be thinking about in that context?
Great question. And yes, some of the same concepts we've been talking about, not only in terms of services such as these, but even in terms of avoiding mass gatherings, or how school educational services or religious services are provided. If there's a possibility of going towards virtual visits to be able to minimize the interpersonal contact, those would be important steps to take.
And how about, like, we also have coordinated entry access points. So this is where people are coming to you know, get referred to homeless services or get assessments. And these are, you know, these vary a lot, and some of them are high traffic areas, and you know, so there's a lot of like one-on-one interviewing. And so again, what, like in this context, like what are some of those steps that you'd recommend?
Yeah, so it's not unlike the situation in all public places or work sites, where we encourage you to think about hand hygiene and being able to provide either soap and water or alcohol-based hand cleaner, which I recognize can be a challenge from personal experience. But being able, if gels need to be provided, thinking of ways to do that in a supervised setting. One situation I've observed is that someone is actually standing there to provide a squirt of hand gel so that people can sanitize hands. Similarly, having availability of tissues can be important. And think about high-touch areas also, and frequently disinfecting those with disinfectant wipes.
Great, thank you. And Marlisa, I'm wondering if you can piggyback on that. And like a lot of the questions are like, should we close these things? Should we stop doing, our monthly site visits? Should we, restrict the number of coordinated entry access points? How should people think about that trade-off there?
Well, I mean, it's really thinking outside of the box at this point, and if you have an idea and you're not sure if it's going to, meet muster, feel free to submit an AAQ and we can weigh in on that. But, case management can be pretty flexible. So, if instead of doing a face-to-face case management session, you could do something over the phone. There's flexibility there. Or, if it is in person, if it has to be in person, getting six feet distance, and then coordinated entry points. I mean, I think that where we can keep the same connection with people experiencing homelessness, that's going to be really important, so that they're not slipping through the cracks. We're not losing contact with them. So that would be another situation where maintaining operations is really important, but then thinking through ways that you can adjust normal operations to include those, personal protective processes, and to keep staff and other, and our program participants safe.
Yeah, and I would just piggybacking on that, just add that, and I think being creative is just incredibly important. We have, if you have someone who you feel you're concerned about, and so you want to make a face-to-face site visit, talking through the door can be a way to make people feel comfortable, and that they're not, going to get, that you won't be transmitting anything to them, but you can still sort of check up on people and get a little better sense of how they're doing. So, things like that can be, incredibly helpful. But also, we're reasonable about this stuff. If you can't make a visit, it just doesn't work, just document it in your case files. No one's going to, those are all reasonable. Those are all reasonable reasons that you might not be able to sort of comply with the precise monthly visit requirements. So, just write it into your case file, and that kind of documentation is fine. Barbara, I know you sort of work with this kind of thing a lot. Do you have thoughts you'd like to share as well?
I do, and I appreciate those as suggestions. I think I would add to that, though, that the population that we work with is so vulnerable, as many of us know, and particularly given trauma histories, triggering events, just the stress of all of this. I worry that at the same time we're trying to implement those kinds of safety mechanisms, we're also going to be seeing more relapse, more higher acuity or crisis, or people who have been told to quarantine who, I don't know about folks on this call, but even myself, you get a little cabin fevered. And so I'm just thinking of how we can come back to this idea of being creative so that we can still be present to do the de-escalation or crisis response to our clients, but at the same time keeping ourselves and our clients safe. So again, it's a balancing of all of that, but I'm anticipating that we're going to have a higher workload for our case managers.
Yeah. So we're coming up to the end of our time. I just want to say a few last words. The main thing I want to say is I really want to thank our panelists on this call today. Especially want to thank the CDC for both their participation in this call, but just their endless partnership on this stuff. All these materials you see coming out from us many other people have a very important and insightful hand in the development of those materials. So, Jay, Sapna, thank you very much for all your help, and thank you for participating in this call. I know it's been really helpful for me, and I'm sure for the rest of our audience.
It's really our pleasure, and I would encourage people to visit cdc.gov/COVID-19, COVID-19. I think you'll really be surprised, maybe a little overwhelmed by the amount of information that's there. There's over 400 different documents that are available with guidelines. And you can also, of course, Google CDC coronavirus and then the topic of your interest, and you may very well go right to what you're looking for. On the website, it is organized in a tabular fashion, so hopefully it will be not too hard to navigate. Thank you.
And we're always here to, if you get questions to HUD to us, we're in constant contact right now, Marlisa and I, so we'll be able to try and get some answers to you, and sure there'll be more communications to come.
Yeah, and if you're submitting AAQs and that require CDC expertise, like we're all talking to each other to make sure we get the best information out to you that we possibly can. Also, I just want to recognize there were a lot of very specific questions about program operations and deadlines and all those kinds of things. Most of those would have been really hard to answer on this call. Please go ahead and submit AAQs to us for those kinds of things. We will answer as much as we possibly can. We are obviously prioritizing questions around this topic. And please feel free to reach out to us if you have any sort of pressing questions or information you'd like to share with us. We will continue to try and get as much information out as possible. I also want to thank our friends from VA, from our Office of HIV/AIDS Housing here. I want to thank Marlisa and Brett from SNAPS, and Barbara from NHCHC and our TA providers who have really just put this stuff together. I also just want to personally say thank you to the many, thousands of people who are out there doing this, working with people experiencing homelessness every day. This is an incredibly challenging time, and I am constantly impressed with just how much people have stepped up, both to ensure the health of the people they work with people experiencing homelessness, but also just tireless advocates for, ensuring that we do the right thing for people experiencing homelessness. So thank you all, just from the bottom of our hearts, for all the work you're doing. And with that, we're going to conclude the webinar. I hope everyone has a great rest of the day, and I'm sure we'll be communicating with more information soon. Thank you.